in my forever home. Now I hope I can find my forever home. So give me your forever.
That's okay, I did the same thing, Deb. Why don't we go ahead and get started? I'm Stuart Black, for those of you who I haven't had the pleasure of meeting, and I know it's a smaller group, but this is a very important opportunity, I think, for all of us to share some thoughts and some ideas about some of the new changes that are taking place and how we're going to be reimbursed. Got something caught in my throat, I'm sorry. Before we start actually going into some of the details of MACRA and some of the other issues that we're faced with today, I want to just share some thoughts with you because it's very important for you all to understand that none of us here are going to be talking about anything in regards to making recommendations for your practice or things you should do or things you shouldn't do. This is an opportunity to share information, and I've always felt that one of the primary objectives of the Texas Neurological Society is to do just that, and that is to share information. But I want to again emphasize that every person individually within their own practice has to look at their practice and basically do the math. First of all, what we're going to be discussing in regards to MACRA are proposals that were recently introduced by CMS with the presumptive final conclusions for this being 1 November of this year. I will suggest to you there has been a significant write-in and a significant amount of marketing from people who are not happy with this situation to CMS. And CMS, as of 2 days ago, if my memory serves me correct, already hinted that 1 November may not be the start date at all for the final proposal. So that means then that we are going to be talking about the proposal that CMS made with the understanding that theoretically there will probably be some changes, significant changes in the original proposal based on some very strong criticism from colleagues around the United States and societies, including the AAN. In addition to that, when you look at this data and when we start to identify actually what MACRA is all about, because it's going to be a paradigm shift in how we're paid, again, as I indicated earlier, it's very important for everybody to look at their practice model because we all have different practice models. We're in different size groups, this, that, and the other, because I will suggest to you that there will be a significant number of physicians in this country who will choose to take the penalties that are built into MACRA as opposed to trying to comply with MACRA, and that means then that it is not a free ride because, first of all, just the expense of meeting some of the obligations of MACRA have to be factored into your practice model. For example, it's going to be EHR driven, obviously. So every EHR is going to have MACRA certification. Well, you're going to probably wind up paying for that if your vendor is going to go that route. And not only that, but you need to be very sure that when your vendor says we will be certified by MACRA, that it is also for the long haul, i.e. not just 1 year, but subsequent years, and I expect that that will be an additional cost. So the take home, before I even begin this discussion, is that every practice has to look at their practice and identify what the balance sheet is in regards to whether or not the penalties are going to be less burdensome, if you will, than actually complying with MACRA, and again, it's going to be variable. So we're going to jump into this, and my half of the discussion will be just basically about MACRA, and to introduce you again, as we did last year when Eddie was up here. Eddie, where are you, Eddie? You must be in the audience somewhere. At any rate, And we're going to kind of get a little bit more detail because we have more information. And then I'm going to have Katie, who is the the director, you're medical now, you're director of medical economics for the American Academy of Neurology. We're very honored to have her here, tell you what a magnificent job your academy is doing in trying to navigate some of the issues and help the membership. I just used your name in vain, Eddie. That's all right. You serve you right for being late. Okay, so let's jump right into it. Is this working? Where do I have to push? Where do I have to fade? I am pushing the green button. Oh, there you go. All right, so let's just kind of walk through and some of my perceptions of really major timing in our careers, many of our careers anyhow, and that started, I was actually in practice, not in practice, but I was a resident in 1965 when Medicare came about. Well, I mean, that was a very major change, and I will tell you, when I entered practice as a neurologist, and some of us are gray-haired enough to remember those days, there was a significant amount of anxiety, and there were doctors saying, I'm going to quit medicine because Medicare is here. Well, you know, that was a long time ago. Medicare survived, we survived, we're all here. But then it became clear that this term, usual and customary charges, was not the way things were going to be successful for funding this program. And by the way, as an FYI, the first Medicare recipient was Harry S. Truman, and the Medicare bill was signed in the Truman Library by LBJ. But in 1992, that was the introduction of RBRVS, all right? And with RBRVS, of course, you all know, came CPT coding and E&M coding and all the things that we're doing today routinely. That did away with usual and customary charges. And that was supposed to really have a tremendous impact on decreasing our economic burden that had been associated because, as you'll see in a moment, the scale for how the cost of medicine in America kept going up and up and up. But with RBRVS, that didn't seem to be a sustaining cost control. And we all know Obamacare, which is another name for the Patient Protection and Affordable Care Act, or ACA, was introduced in 2010. I will suggest to you that now we have MACRA, which is on a line and equal to these changes and major changes that have taken place in how physicians are paid. And MACRA is a spinoff of the Patient Affordable Care Act. Now, these are just some statistics. I'm going to use some of these statistics as we move forward just to kind of bring you up to date as to some interesting things that you may or may not know because they are interesting. So in America, we have about 916 or 17,000 physicians. This is 2014 data, but you know that this data is always a few years behind. That number, we really have about 785,000 who are practicing, and probably more now. But really, in our academy, I think, and Katie, correct me if I'm wrong, we have about 30,000 academy members. But when you break it down, at least in the statistics I looked at of who are really practicing, you give or take about 17,000 or so are practicing neurology. That means that we're a real small group. We only represent, 2.1, 2.3, 4, whatever it is, percent of all actively practicing physicians in America. Now, this number is a very important number. We spend, in 2014, $3 trillion for Medicare spent, $3 trillion. $3 trillion on the care of our senior citizens. Not even 2 weeks ago, 10 days ago, 2015 data came out, and I didn't have a chance to change the slide. We are now up to $3.4 trillion, $3.4 trillion for 2015, which is also unsustainable. And now the cost per person in the United States, and of course we have 340 million people in the country, is averaged out. As you'll see, very different populations are using a lot of it and others aren't using any. But we're now up to over 10,300 hours per person in America annually that CMS, if you look at it as an average, pays out. So what I did was I went and I did something that I wanted to do for myself, and then I decided I thought so interesting, I'd share it with you. I wanted to see how much of this 3 trillion or 3.4 or whatever it is, how much really is involved in the actual care of patients. And it turns out that about 2/3 of it is. So we spend about $2 trillion of the 3.4 or 3 whatever trillion in the actual care of patients. These 4 categories, in my opinion, represent at least examples of the care of patients, which means that we have about $1 trillion that's being spent in managing this program. We have about not $1 billion, $1 trillion that is spent in other areas other than direct patient care. So clearly, with the Affordable Care Act, a lot of other businesses have sprung up which are eating up a lot of economy that I think people need to be looking at. In regards to neurology, in 2012, neurologists, and remember only about 2.1, 2.2%, neurologists only spent of this money, of this $3 trillion, $1,271,000 or whatever it is, $333,000. Okay, so we represent about a 0.6% of Medicare expenditures. I thought those were interesting statistics because we're not even allowed to be able to participate in the primary care initiatives that are being given, even though we do E&M, and yet we only account for this amount. As it turns out in our country, 5% of our population takes about half of the expense, and 5% don't even have any expense, hardly at all, okay? Now, as I said, the curve at what percent of our expenditures eats up our GDP, and that's why it's unsustainable. You can see that these are countries that all have reasonably respectable health care systems, but from the very beginning in 1980, we started to really escalate. And here's where is it, 92? Here's where RVRVS started, and in this area here, look how far there was a difference. We really spend a lot of money, and right now we're almost at 18% GDP, according to the statistics I read about a week or so ago. Another interesting thing about this initiative, and by the way, we keep going up, and another interesting thing that is important, if you just put America, USA, right here and say, okay, these numbers are now going to represent the percentage of physicians per population, and we have 900,000 plus doctors, or 700 or so practicing, with a population of 340 million. So basically, we are not doing very well either in regards to the number of doctors we have to care for the number of people we have in this country. We are actually just about in the middle of the countries that have reasonably successful healthcare systems. So now, what's MACRA? With that background, what's MACRA? Well, MACRA is an acronym, obviously, for Medicare Access and Chip Reauthorization Act. It was passed in 2015. Now, this is a very interesting point because there's a lot of, as I mentioned from the very beginning, there's a lot of stuff that's going on, both politically and both economically and in every way, shape, or form over this thing. But look how the vote turned out to pass MACRA. It's a bipartisan vote. Well, guess what's going on now? A lot of us have been lobbying our congressmen, our senators, and when the SGR was repealed, everybody was so excited, so happy. Remember, it was a big thing, splashed out, SGR is repealed, we're fine. Well, this is what replaced the SGR. The SGR was a product of the 1997 Balanced Budget Act, again, in hopes of trying to decrease expenditures, but there were 17 fixes, as you know, at the expense of a significant amount of money, which I'll show you later. But in the meantime, what replaced SGR was MACRA, and the senators and the representatives were not informed of what MACRA is all about. So now that they're starting to learn about MACRA, fortunately for us and hopefully for us, we're getting a lot of pushback from some of these folks here who voted for MACRA saying, this isn't a good deal for the doctors, and I'm not really sure it's a good deal for the United States healthcare system. So again, as I mentioned from the very beginning, this is a very dynamic state, and I'm not sure, and nobody knows exactly what the end product will be. Now, when MACRA was passed, as I said, there was enthusiastic support for it, and that means that over 750 national state-based physician organizations, including the AMA and others, were very much in favor of it because nobody knew what it was. But now that we know what it is, things are starting to change. So some of the language in MACRA, for example, says we're actively engaged in transforming care. They're going to be in MACRA, and you'll see from some of the slides I have in the future, that there are going to be definite winners and losers, and I will suggest to you that the winners are going to receive money from the losers. Do I have to ask anybody here what the percentage will be of losers versus winners? We'll look at some of those. Believe me, there aren't going to be that many winners compared to losers. So this is so MACRA is basically a fee-for-service model, but it's totally modified and revamped fee-for-service. Now, this price tag, just to put MACRA together, is not insignificant. The bill is calling for a $210 billion price tag, so some of it, or 70%, is going to be paid by reducing Medicare entitlement reform. But this is another important thing. Medicare, for those of us who are old enough to be on Medicare, is going to rise. It has risen, I might add already, but next year, by 2017, we'll have significant rises. If you earn as a senior, now by the way it's calculated is your last year's tax return. So let's say somebody here, let's say I retire. If I retire and my income goes to zero, whatever I made this year, or in the last 12 months, is going to determine what my Medicare bill will be. Well, I mean, there's a difference, though, in my salary, because I'm not making any money now, but I may have been making, what, $250,000, $400,000, well, it doesn't matter. The point is that makes a big difference in retirement planning. And here's the way it works out. So as I speak, give or take, I think it's $240,000 or $250,000. If somebody made $240,000 or $250,000 the year before they retired, or take, their new Medicare, start Medicare, excuse me, or if they renew their Medicare, their premiums are going to go up about 60%. 60%, okay? And if you're making about $320,000 or something like that, you're going to have an 80% increase. So basically, if you're in the $300,000 range and you are a man and a woman and you're retired, your Medicare is going to be $25,000 a year for Medicare, because I've done the math for personal reasons. And so it's really significant, and this is all part of funding MACRA. And others say, well, how is the rest going to be paid? Well, nobody knows. Well, everybody knows. It's going to be added to the national debt, and other things will be cut, and other things will be risen. So let's talk about this law, okay, that is proposed. Again, it isn't finalized. I want to keep emphasizing that. And MACRA is divided into two tracks. One is called MIPS, which is Merit-Based Incentive Payment System, which I would say 95% of physicians will be doing. And the other is alternative payment models, which we'll talk about both, and what the criticisms are and some of the issues that a lot of people have with these things. So let's talk about MIPS first. I'm sure everybody here has heard MIPS, they know what it is, but I'm going to try to be a little more compulsive in identifying some of the nuances of MIPS. It is fee-for-service. And you've all heard, well, fee-for-service isn't going away. You may want it to go away, really, under this model, because it is really a very difficult model to follow, as you'll see. Now, unlike fee-for-service in the past, reimbursements now will be based upon physicians' performance scores, and those scores are going to be based on performance measures, which we'll talk about, okay? And everything that is being done, and your scores, by the way, your MIPS scores, will be reported publicly on the CMS website. I would also suggest to you that although this is a CMS program, and I've had much discussion with colleagues even this weekend, we all know that indemnity insurance is very strongly behind this, and the reason is obvious because it takes the risk of what the insurance companies have now. We know, like, for example, Blue Cross Blue Shield, dropped funding the exchanges. It takes the risk off of the indemnity companies and off of CMS and puts it on us. So why wouldn't insurance companies be 100% supportive of this? It's clear. So obviously, when we say, well, no, I'm not going to see Medicare patients because this is just a CMS program, well, that would get us through this for a short while. But I guarantee you, and in fact, it's mandated in MIPS, when you read it, was it 996 pages, right? 996 pages is what it is. There's a part in there that says Medicare will insist that indemnity insurance will either follow MIPS and or develop their own program as a clone of MIPS. So it's not going to be just Medicare. Who's exempt? Well, aren't that many. If you're just starting practice, you're exempt for a year. And basically, if you are a low user of Medicare and bill out less than 10 grand and have less than 100 patients, then you can be exempt. And then, of course, you'll be exempt from MIPS if you're in the specific alternative payment model, and we will talk about that as well. So moving along, these are the old measures that we've used, and this is what we're using currently, PQRS, meaningful use, and VBM, value-based medicine. So MIPS is going to consolidate all of these things into a different model. So MIPS now has 4 measures, all right? The first measure is quality, which is going to be 50%. And when I say percent, kind of think of a percent as your scorecard, because you have to get 100. And I'll show you what I mean in a moment. So, but quality is going to be handled a little differently too, because now we report our quality measures. Well, under MIPS, it's going to be a little different. Not only do you report quality measures, but you will have to show metrics and data to show that you have adhered to doing those quality measures. And that means then that Medicare has already stated that they will selectively be monitoring practices once a year with audits. Every practice who's in MIPS once a year will be monitored with audits to make sure all these measures are met, but focusing on quality. Not every practice, they'll be doing it selectively, but they're really building a big force to try to maintain that ability to do. The old meaningful use is transferred into what's called advancing care, and that's 25%. As I mentioned, this is your computers are going to have to be certified. This could be an additional expense. You have to make sure, even if you pay the upfront expense, that your certification group or your vendor is going to continue to certify as the years go by, and that may be additional expenses as well. So it is not, this has changed as well. This is a new thing. It's called Clinical Practice Improvement Activities, CPIA, as it's affectionately known, and I'll talk about that very briefly. These 3 things you'll be reporting cost, which is VBM, but cost is what Medicare will be identifying from your claims. So you won't be reporting that, but it'll be identified through your claims. Now, I want to just briefly introduce you to this new thing, CPIA rather. There are 6 categories that'll be measured, and this is to try to, this is practice improvement. This is what they look at as practice improvement. So they want to expand the practices, this population management, care coordination, beneficiary engagement, which means they want your patients to participate, patient safety, et cetera. And there's 3 more that have been added under the MACRA proposal. These are such things as chronic care management and having your patients participate in their plans and things of this. Make a long story short, there are 90 of these now. Now there's 94, I think, actually, since I made this slide. And it turns out that each one is giving a weight. So you can do anywhere from 1 to 6, but it depends which one you choose, and you may get all of your points to complete this as a complete category with this one measure, but you may also improve it even more by doing more measures. But again, these are all going to be having values added to them, and this is a work in progress. So just to look at this one more time, the good thing is we've gone from 9 measures to 6, but at the same time, it's going to be based on outcome. It's not just reporting. They're going to be monitoring you with audits to see that you have done this. And by the way, FYI, for those of you, it's a mixed audience, everything I'm talking about applies to whether you're in private practice or whether you're an employed physician. It doesn't matter. It's all the same. If you're an employed physician, because I work with our employed physician group, HCPN, Health Texas Provider Network, we have 1,000 doctors, and they have to meet these requirements as well, or else they don't get their salary. I mean, they're going to get dinged, because I've already talked to how they're going to handle it. I don't want to do it at school, but they're all going to do the same type of thing. This is some of the changes in meaningful use, and I'm not going to belabor this. You have these slides, I think, or you should. If not, we can get them for you, and I don't want to go through all these things, but I put them here for information as much as discussion. I said that CPIA is 15%. Again, these are your numbers. You add them up, they'll be 100, and then resource use, okay? Now, these are some 8 important facts about MIPS that I put down because they're very important as we go forward to trying to understand this whole mechanism. So the first year, everything is going to be put back 2 years. That means that whatever your MIPS score is going to be based on information that they've been able to accumulate for you 2 years ago, which means then that starting 2017, 6 months ago from now, that's when your MIPS score for 2019 is going to be calculated based on the old measures. 2019, everything shifts over to the old measures, and all the stuff that we did 2017 and 2016 is gone. So as of 2017, your MIPS score for 2019 is being calculated. So basically, that's what this says. In 2019, the MIPS composite score will be based on the 4 performance measures because the other 3 will go away. This is the budget neutral program, so that means that's another way of saying there are going to be winners and losers, and everything has to balance out because Medicare feels that they don't want to, and they're not adding any money. I'll show you in a minute how Medicare will make a lot of money from this. As I said, there's winners and losers, and there's something called a scaling factor. Some of you may know what that was, but I've talked to nobody who knew what it was because it's an actuarial term that I had to talk to an actuary to find out what it was. And what a scaling factor is a ratio between 2 sets of measurements. And what it boils down to is if you have, as you'll see, certain people below 0, and others who are losers, and others above 0 who are winners, this scaling factor will equalize out that information so that the end result is 0, but that'll also be able to give money from the losers to the winners. It's very complex. If I begin to tell you how complex this 996 pages is, it's mind-boggling. But at any rate, the scaling factor can actually even further increase the winners by a factor of 3, and I'll show you what that means. All providers initially this is good news, starting 2015 through 19, all providers, whether you're doing MIPS or alternative payment models, get a 0.5% annual increase. We're in that mode right now, which gives you then up until, I think the next 5 years, a 2.5% increase, then is flat funding from 2020 on. And in addition to that, there's another interesting thing. It's called an exceptional bonus pool that Medicare has set aside, which is $500 million. And that actually is going to be paid out to super achievers who really are doing a super great job, and I'll show you what that means in just a minute. So what I've done here is I've tried to put in the next two slides 3 examples. It's so complex, I wanted to show it to you in 3 different ways. So the first thing is, this is what I've just said. So think of this line as 0. And everything below 0, you're a loser. Everything above 0, you're a winner. I mean, that's what it boils down to. Now, if you're not doing well and your MIPS scores nationally are below the average, which is called the performance threshold, you're going to lose money, but if you get to be the lowest 25%, you're going to lose 4%, 5%, 7%, and 9% in these ensuing years. That may not sound like a lot, but it adds up. Conversely, if you're a winner and you're doing super great, it's just the same. You have the sliding scale that brings you up to a top, and you can earn extra above everything else, above what your contracts are, 4%, 5%, 7%, and 9%. And in addition to that, I'm going to show you in the next slide that when you add the scaling factor, and in addition to that, the exceptional performance measures, you can really earn even more than that. And this is what it's going to look like. So if you add the scaling factor, you wind up with 12%, 15%, 21%, and 27% because of the factor of 3. That means these guys down here are losing that. Okay? Now, another way of looking at this is the same thing I showed you, a different format. This is your performance threshold. This is the average nationally. So, excuse me, right here. So if you are losing, you're going to lose a proportion of your income, and then at the 25% level, these are the numbers you're going to lose. Conversely, if you're winning, this is what you're going to win. And then if you add the scaling factor, you can get up to 27% more than what your contracts are. And then that is not including the $500 million bonus. Well, that sounds great. And if anybody were to tell me that there are going to be a whole bunch of people up here, I'd like to bet them. It's better than betting on the last horse in the race. I can guarantee you that. So the reality is there are going to be tons of losers. And when I show you the statistics that's actually in the proposal, it'll blow your mind. And there'll be very few, and if any, winners of that nature. But, you know, it looks good on paper. Okay? Now, that's track 1. Now, let's talk about track 2. Remember, that's the alternative payment model. So what are alternative payment models? Alternative payment models, these are some examples of ACOs are the most common medical home, but it's not just a normal medical home. As you can see, it's going to have to be a totally different type of medical home. Shared savings, pay for performance, it goes on and on. But the bottom line is when you're looking at joining an alternative payment model, you need to look at who's in the bus with you. And the reason for that is because, remember I mentioned earlier that your scores are going to be based on the prior 2 years' experience. So let's say that I decide that I'm going to join a group, and I'm doing great, man. I'm in the upper, 20 percentile, 25, whatever. I'm going to join a group because I can't do it anymore. I'm a solo practitioner. I just can't do it anymore. I'm going crazy. I got to get a break. So I join a group. Guess what happened? All of the data that I had goes away, because it's all tied to a TIN, your tax ID number. And when you join that group, MIPS insists that you can only be under one tax ID, alternative payment models insist that you can only be one tax ID number. So that means I inherit whatever that group, and if they were doing worse than I get screwed, basically. So you got to be very careful when what you're doing, because you want to make sure that you don't get into a situation where you were doing better than what you're actually getting into. That's how it works. And by the way, if this sounds a little confusing to everybody, I've spent the last 3 months trying to understand it, and I feel I'm just an amateur, believe me, but I probably know it fairly well. It is, nobody knows what's going on. It's as confusing as can be. What?
You know more than Congress does.
Either that or I'm a good BS or one or the other, right? Okay. All right, so now let's talk about alternative payment models. So this is the rule, and these are the current alternative payment models that are available. Well, I'm putting this up for a reason. Now, I'm in a big ACO. I'm in in fact, it's the largest in the country. We have 2,700 doctors at Baylor ACO, Baylor Scott and White ACO. So we were all walking around in ACOs, and I've talked to colleagues around the country in ACOs. Man, we're going to be an alternative payment model. We're cool. We don't have to worry about all this MIPS stuff, because if you're an alternative payment model, you don't have to do MIPS. It does it for you. We were so happy until the blanket came out, and that was about a month ago, maybe 6 weeks ago. It turns out that none of the ACOs are going to apply are going to be meeting the requirements of an advanced ACO, because you got to be a track 2 or a track 3. Well, there are very few track 2 or track 3s, or you need to be a next generation ACO. I'll show you this in a minute. Other things are, these are the other 2 models which are specific to companies. So of all the alternative payment models that currently exist, a very, 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 very few will meet the standards to not do MIPS. And here's how it breaks down. To qualify for what's now called an advanced ACO, which very few do, these are the 3 requirements that don't look like much, but it turns out that CMS, not me, not anybody else, this is written in the bylaw, in the literature, CMS says about, remember there were 700 and some thousand doctors, right? CMS said that 30,000 to 90,000 physicians of this number of physicians are going to be able to not have to do MIPS, because they'll be in an advanced ACO. An example of an advanced ACO would be Partners at Mass General, for example. All right, that's an advanced ACO. Very few, and in fact, here's the breakdown. The breakdown is there are 407, we'll try again. As we speak now, as I made this slide, which was about, I don't know, a month ago, there are 787 ACOs in America, which account for 23 million lives, all right? Of that number, there are 477 Medicare ACOs, most of which are all MSSPs. There's a couple of pioneers left around, a few next generations, as you'll see, and then these comprehensive models. Which, when you break it down further, there are 433 Medicare ACOs, but only 22 are track 2 or 3. 22. And here I'm in the largest one in the country. We don't qualify. Of that also, there are 21 Medicare Next Generation, which is the newest form of ACO. So that means basically the bottom line is that being in an ACO today doesn't mean a darn thing. Doesn't help you at all. Unless you are one of the lucky ones. And I don't know how lucky you are. But it turns out that that means about 5% of all Medicare ACOs will qualify for an advanced ACO. 5% of the 787. At the same time, about 11% of all Medicare ACOs, that means 11% of the 477. And that means that overall, 7.1% of all ACOs, including Medicare, will be qualifying for an advanced ACO. And that's where you come up with these numbers here. There are very few people who will benefit from that. So it was a come on, but it really, so basically, it doesn't really help most of it. I bet it doesn't help anybody in this audience. So what is an advanced ACO? Well, I just put 3 little things down, but I'll suggest to you that you can read this, but an advanced ACO means they take risk. Why is this a good deal for the insurance carrier? Why is it a good deal for Medicare? I told you, because we take the risk and they're off the hook. And if you don't, for example, if you have a certain expenditure model that you've met and you don't meet that, the ACO or it could be any of the APMs, they're going to have to pay back at least 30%, and it can be up to 60%, depending on where you read, of what they owe. So there's a lot of ways they pay it back. They don't get paid for their services for a year, things like that. This is what it is. All the risk is on the physicians and the entity. Now, what are some of the concerns about this? So I've already mentioned most of them, but one of the major concerns, and this is really being verbalized very strongly in Medicare right now, and everyone's saying, this is ridiculous. Nobody can meet these rules. I mean, why even put them in? It's a come on. The bottom line is that the definition for an advanced APM is outrageous. And so everybody is complaining, and now there's talk back from Medicare that, yeah, maybe we overdid it. And this is what the congressmen, this is what our senators and our congressmen are very angry about, because they want to put people into a APM, and nobody's going to go into APMs if there's no benefit for it. At the same time, remember that the APM must bear more than the, quote, this is a quote from the paper, more than normal risk, but unfortunately more than normal risk has never really still been defined. So we don't even know what they're talking about, nor do they. So when you talk about advanced alternative payment models, you have, track 2, track 3, ACOs, you have bundled payments, and you have other types of payments, but the bottom line is everybody's going to wind up doing MIPS, except those who are in some of the very, very large ACOs like Partners, for example, at Mass General. Another thing is that if you belong to an ACO, whether it's a qualified ACO for advanced or not, your distribution of income will also depend on your participation in the ACO, which is it can be one of 2 ways. It's going to be based on either the percentage of payments through the APM that you're receiving as an annual income, or the percentage of patients that you're seeing through that APM. And this is actually from the paper. I just put it into a slide form so you can see. So when you get up here in 2014, that means 50% of your payments have to come from the advanced payment model. And if you don't have that, that means 35 through the advanced APM. You see why these numbers are very important when actually the discussion on physician-focused payment models starts, because if we have a PFPM, for example, we have 2 that we put together, and we hear about them in a moment, on headache and from the academy, and epilepsy. That means that 35, and then in 2016, 50% of your patients are going to have to meet that criteria. Well, how many of us have that many patients with these diseases in our practice? Yes, sir.
And there's, at this at-risk situation, there's no way, actually, like an insurance company would do, of actually screening for high, significant disease patients that are high consumers of the resource, right?
Right.
So if you have to live in a community where you got
That's right.
sick folks,
Yeah.
you're in an ATM, you're screwed.
That's exactly right. Yeah, it's really interesting, isn't it? So I'm coming at the end of some of this good news for you guys. So there's another type of APM, though, that is more palatable, and that's called a MIPS APM. So what does that mean? Well, that means you're not qualified to be an advanced APM, but because you are doing quality work and you're trying to do a good job and all this sort of thing, CMS has offered you a fig leaf and basically indicated that if you belong to a MIPS APM, you may still get a break on your reporting because you can let the APM do your resource reporting. Quality will be reported through the APM because that's what the APM is supposed to be doing. And all you'll have to personally report is CPIA and your old meaningful use. Well, that's an advantage, and that does help. So, for example, at Baylor, what we're trying to do is become a MIPS APM. We're not going to be track 2, track 3, but it'll be a lot easier for our reporting. In other words, the laborious amount of work will be reduced because it'll be done by the administrators of the APM. I mentioned earlier that medical homes are a possible APM, but I want to also emphasize that a medical home has changed also because now it's called a comprehensive medical home. I'm not going to go through this, and you can do it on your slides, but these are the requirements of becoming a comprehensive medical home, which means then that too is very, very detailed, to say the least, and there's all this risk involved as well. And to my knowledge, there are to date, no comprehensive medical homes available, to my knowledge. I mentioned before that there's a new form of alternative payment model, and we'll be hearing more about that when I finally keep my mouth quiet. And that's the patient-focused payment model. And that can be used in an APM, it can be used with MACRA, it can be used in MIPS. So it's a very versatile item. And what that will be is then we're encouraged. Actually, Medicare is encouraging societies to produce these types of models, which would still be MIPS, but at the same time, it allows individual physicians under the umbrella of a society like the AAN, which you'll hear about, to be able to participate with, I will tell you, and I'm not just saying this, I really mean it from my heart, our society, our AAN, has done probably one of the best jobs in the country of any society to make this happen for our membership, which you'll hear shortly. So what is the goal then for the value-based triggers? It's very simple. The goal is that, these are the numbers that are important, and that Medicare wants 30% of fee-for-service tied to APMs by the end of 2016, and 50% by 2018. That ain't going to happen. It ain't going to happen because nobody can become an advanced APM. Now, maybe they'll switch the gears and make it a MIPS APM, which I just talked about, which is a little more palatable, but the breaks, the money you can earn is going to be markedly reduced under that model. They also want 85% of Medicare fee-for-service payments tied to quality metrics by the end of 2016 and 90% by 2018. We're doing well as neurologists. What is it? We have about 85% of our people are doing measures now, are doing PQRS. Isn't that right? Something? Huh?
PQRS, no, it's around
60%. Well, okay. Okay, 60%. But nationally, it's even less than that. Less, 40%, I think, something like that. So you see, they want 90%. So we'll see how that plays out. I'm almost finished with this part of the discussion. I wanted to just let you know that the codes will change. You'll find a ton of new codes that will be coming down because now MACRA also wants physicians to be designated as to what role they're playing by codes in the patient's care. And if we can't decide amongst ourselves, because, there's literature to say that a neurologist, there may be as many as 18 other doctors on a case if you're a neurologist in a clinic, and certainly in the hospital, our neurohospitalists that see our patients at Baylor, I mean, there's like tons of other doctors involved. And if the doctors can't decide who's going to be really in charge, then they leave it up to the patients and patient's family to do that. Again, this is all proposals. These are not set in stone. I want to keep emphasizing that. Now here's the last couple of 3 slides is where I'm going to really show you how difficult this is going to be. Of the 996-page document, on pages 672 and 75, I copy this out. This is actually a copy. So what does this say? This says this is the MACRA, and this is dealing with MIPS. All right, this is a MIPS. And what this is in the proposal. This is in the proposal. I did not get this out of the literature. What it says is percentage of eligible clinicians receiving MIPS penalty. In other words, who are going to get hit with penalties? Look, if you're in solo practice, 87% of doctors. Now, that's 87%. This is in the proposal. If you're in a group of 2 to 9, you have a 70% chance of losing. If you're in a group from 10 to 24, you got a 60% chance of losing. The only guys who are going to possibly come out as winners is if you're in a group of 100 and more. Now, this hit the news. I mean, some of you might have seen this in the newspaper. This was actually on the news. I watched it on television. I saw it in the newspaper. So CNS response was, we may have overestimated this because this is really data from 2014 where only a few people were doing the quality reporting, but it's going to go up in 2015. That was their answer. Well, use your own imagination. Now, I did the same thing on pages 676 of our 996-page proposal. I copied this out for neurologists. Well, we're doing a little better because we do have 60% or whatever the number is of us who are complying to some of these quality measures. But here's the same thing for neurology. Percent of neurologists who are going to fail, 40%. The percent of this is a prediction in the paper. This is from the paper. The percent of neurologists who will succeed, 60%. So we have a little bit better, but that means that 40% in this room are probably flunk. And you're going to owe money, and you're not going to get paid very much. That's what this boils down to. There's another way of looking at it as I sum up everything. Remember I said I can't read that, but right now up until 2019, everybody, whether you're in a MIPS or an alternative payment model, this is MIPS, this is an alternative payment model, we're all going to get a 0.5% increase up to 2019. 2019, everything changes. Under MIPS, everything flattens out, but then you have to go into all these 3 different things I showed you. If you're in an alternative payment model, and obviously this shows you how hard Medicare is trying to push everybody into an alternative payment model, which nobody can do. But anyhow, if you're in an alternative payment model, every year you get a 5% increase. You don't have to do MIPS. You get a 5% increase. And then at the end of 2026, if you're in MIPS, you get a 0.25% increase. You get a 0.75% increase. So this is just another way of showing what I had showed earlier in summary to try to illustrate what the goals are, if you will. And this is the next to the last slide, and this is a little algorithm I put together. So if you're an advanced APM, which very few people will be, and you do meet the criteria, then you have to decide are there enough patients or enough payments and or patients to allow you to use that APM as your escape from MIPS. And if it's yes, then you don't have to worry about MIPS. On the other hand, if you're in an advanced APM or any APM, and you don't have enough patients, then you got to go into MIPS APM. That's a MIPS APM where you don't have to do 2 of the reporting. On the other hand, if you're not on an APM, very few people, like the first-year people or those who have low volume, then they're not subject to MIPS, but everybody else will be subject to MIPS. And my last slide, before I turn it over to Katie, is a takeaway. And the takeaway is MIPS is, again, a culmination of a 12-year, $169.5 billion payout that SGR did over 13 payments. So that's why everyone was so excited, because remember every year the doctor fixed, that's what this is all about. Well, this is what we got it replaced with. So MACRA is not just a way of getting paid. It basically changes the way Medicare pays clinicians, and I would suggest indemnity insurance will follow, and offers financial incentives, but it also offers penalties. And there'll be a lot more people getting penalties than there will be getting bonuses. Got a bug in here. Medicare B clinicians will participate in MIPS unless they're the first year or are low volume, and the MIPS payment adjustments will begin in 2019. So remember, 2017, we're starting to develop the data for 2019 when everything changes. So my take-home is before committing significant financial investments to comply with this program, I think a prudent neurologist would review their current practice strategic plan and their practice model and carefully evaluate this as to whether or not it's cheaper and better to take the penalty or to just go forward with this. But one way or the other, a form of this is going to be what we're going to have to deal with. So our options are, there are a few angry people around about this. Every so often I find somebody who's not a happy camper. On the other hand, there are others who are much more optimistic and say, we're going to embrace this and we're going to do the best we can with it. And then there are others who are just going to sit down and say, I'm just going to sit it out and see what happens. With that, I'm going to turn over to Katie. Thank you. Are you hooked up? Okay, don't forget to.
I'm going to use the podium because I've got notes. A little less experience than Dr. Black. Thanks so much for having me. Hopefully I can bring a teeny bit of optimism after hearing that. Excellent presentation from Dr. Black. But really here to talk to you and excited to talk to you about two big initiatives that the AAN is currently undertaking to help ensure neurologist success under these new payment programs. We're here with you as your academy, and we want to do everything that we can to make sure that people are successful and that we are helping you through this very complex transition. So first I'm going to talk about our brand new clinical quality data registry called Axon. I've spoken to a few of you about Axon at the table throughout the weekend, but I'm excited to go into a lot more detail here for you today. Then I'm going to talk about, as Dr. Black mentioned, our physician-focused payment models, our alternative payment model frameworks that we're working on specific to neurologic care in epilepsy and headache. And then I'll just generally talk to you about how the AAN continues to advocate to try to make MACRA better. As Dr. Black mentioned, we're in proposed rulemaking right now, so we'll see final rules in November, and we've submitted extensive comments to CMS, as have many individuals, to try to make this better. And I'll share with you just some of our resources, particularly on the website, because as Dr. Black mentioned, things are changing really quickly, and so the website is probably one of the best places to go for information because we keep that updated as things are happening. So first we'll talk about Axon. So the vision of the Axon registry, first and foremost, is really to enable neurologists to use data to improve patient care and outcomes. It will also help neurologists meet federal reporting and board certification requirements, help demonstrate the value of neurology and neurologic care, and then we'll talk a lot more later on about minimizing burden for data collection and submission. So those components of MIPS that Dr. Black was talking about, we're hoping that Axon will be a method for people to submit that data to CMS and centralize everything and make it easier. So what is a clinical quality data registry? They're designed to gather clinical data from a broad cross-section of patients for the purpose of quality measurement and then ultimately quality improvement. So it's different than a research registry. So research registries involve prospective data collection, and it's a little bit more regulated as to who is entering that data ahead of time, whereas the clinical quality data registry is retrospective data collection, and it's considered to be a step up from claims data. So there are benefits to the organization of having a registry as well as benefits to the individual participants in the registry. So particularly for the organization, it gives the AAN an opportunity to demonstrate to policymakers and payers the value of neurology and neurologic care. We, through having the registry, develop partnerships with key stakeholders. There's examples there, ABPN. The ABPN website already lists Axon as compliant with Part 4 MOC. We have an advisors group of subspecialty societies that help us with the registry, and we'll talk about how the registry enables us to have neurology-specific and subspecialty-specific quality measures, so we're excited to be working with subspecialty groups on measures that are more relevant. There's a monetary value of the data, and so we're working through that. We'll talk a little bit more about that as well. The registry will inform educational programs by identifying gaps in care. It will also help us identify potential guideline projects or quality measure projects as we're looking through the data. And then enable us to perform specialty-specific health services research, which I think will be really important going forward to be able to show our value specific to neurologic care and neurologic measures. So the benefits for the individual neurologists that would be participating in Axon, a lot of people who will interact with this might be the first time that they're seeing quality data about their patients and about their practice. So it's just an opportunity to learn about the practice, learn about and benchmark the practice, and then ultimately try to improve upon those benchmarks compared to national and local trends. The Axon registry right now is in a pilot phase. We're working on broadening it, and we will do that in the very near future, we hope. But right now it's free to AAN members, and there has been no talk of ever charging members to be a part of the registry once we open it up, nor has there been any talk of increasing AAN dues for this registry. So this is something that the AAN is really embracing as a member benefit, and we're really excited about it. Just so that you are aware, so there's a comprehensive pilot plan in place to make sure that the registry is doing what it needs to do before, and it's working effectively, and people are happy with it before it gets rolled out to the entire membership. So the plan originally had been to have a cap at 2,000 participants in the registry in 2017. Well, with all these rules coming out and what we're learning, the board of directors is going to be talking at their October meeting this fall about accelerating that timeline. So definitely stay tuned on that. As I mentioned before, the Axon registry allows for the ability to use specialty and subspecialty specific measures, which is very exciting because in a lot of these programs so far, it's probably, and even we look at the data and see that neurologists are largely reporting for PQRS on measures that aren't really relevant to neurologic care. So we're excited about the opportunity to be able to use measures that relate specifically to neurologic care in some of these programs. So the registry right now would allow for reporting to the physician quality reporting system, VBPM, meaningful use, and then eventually MIPS. So helping, again, streamline and enable neurologists to receive bonuses and avoid penalties. Okay, so let's talk a little bit about how it works. So the AAN is contracted with a third-party vendor called FigMD, and they are actually working with 20 other physician specialty societies to develop a similar type of registry. So they have extensive experience in this type of work. We've been very happy with working with them to date. So the data is captured in discrete fields and in clinical notes. Data collection is automatic, and so it doesn't require any additional practice resources. So data can either be pulled out from the electronic health record or pushed by the practice. And some so I should mention, the FigMD, the vendor, works directly with the electronic health record in your practice. And so the practice then works with the vendor to determine which parts of the note need to get pulled out for which measures in order to get to what we need on the registry end. Some EHR vendors don't allow the pull method, some of the larger ones in particular, so there are some practices that have to do a push method. But the push method is a little bit more work for the practice. Everything follows HIPAA and everything is HIPAA compliant. And the data is all automatically pulled, but it's important to remember that you can choose, the practice participating can choose which measures they want to focus on, which data they want to look at, and they don't have to look through everything. So this just gives you an idea about the sections that are being collected into the registry, and it's basically collecting all of the medical record. There's probably about 30 to 40 data points between these headings. So once the data are collected, participating practices will receive feedback reports on how they're doing on each of the quality measures. Now, it's planned that in the future it will be quarterly reports, which is light years faster than Medicare giving you 2 years prior or even just one report every year. But in addition, anybody who's participating in the registry will be able to log in with their AAN ID, their username and password, and see their data dashboard at any time. So you don't have to wait for that quarterly report. Then, when we were talking about the data submission for CMS's various programs, you can choose which data you want automatically submitted to CMS, for instance, to fulfill the PQRS requirements. So this happens once a year at the beginning of the year, and you basically would identify, these are the measures that I want submitted to CMS for PQRS for this reporting year. And the great thing is, FigMD, the vendor, has the knowledge and will let you know if you're missing, for instance, you have to report one cross-cutting measure for PQRS. They'll come back to you and say, hey, you need to pick a cross-cutting measure to also report on. So then once you get everything hammered out, you would sign off electronically that it is okay for Axon to submit this data on your behalf, and then it would just get submitted right to CMS to fulfill that program. Performance can be tracked over time, and then everybody who enters the registry the registry goes back and pulls 1 year of baseline. So everyone starting out would have 1 year of data in the baseline. And then, of course, you're able to benchmark at all sorts of levels, benchmark your performance. So this is showing the actual dashboard that you would see when logging in if you were a registry user right now. The red bar, I know this is a little bit difficult to see, I apologize. The red bar indicates that the performance is less than average of all of the users in the registry, so each line is a different measure on the screen. The green bar would indicate that the performance is better than average, and then the yellow bar would indicate that the performance is at average or 1 standard deviation below the average. It kind of looks orange, it doesn't really look yellow on the slide. But then you have the ability to click into any additional measure to see additional detail. So you could see the trend here over the course of a year. You see your performance, the registry average in blue. You see where you fall in the upper right-hand corner. That was that first page we were looking at. And then you have the ability to look at the plus and minus as far as who are the patients that met and didn't meet the measure. And you're able to click right in and then pop up a list of those patients. A little bit hard to see, I apologize for that. But in the future, this might help with population management. So the quality measures captured in Axon are clinically meaningful. They address a relevant gap in care, and they are evidence-based. They are a combination of process and outcome measures that the Academy has developed. The goal would be to get further along the path towards outcome measures. Medicare has also indicated interest in outcome measures, definitely something that we need to get to. We definitely are aiming to meet the needs both of general neurologists and of subspecialists in the registry. So right now we have 22 quality measures included in Axon, and they span the disease areas listed on the slide. And the plan is to test 2 patient-reported outcome measures, yet in 2016. So the goal of the pilot is really to identify best practices around implementing patient-reported outcomes in practice, not necessarily to look at the validity of specific patient-reported outcomes, but how does somebody actually do this? How do they work it into their workflow? And the idea would be to help build a toolkit for others on how to actually capture patient-reported outcomes and do that in practice. There will be an annual call for measures that we'll want to include in the registry, and they're thinking that we would like to add about 10 measures per year into Axon. So you can select any number of measures you want to assess in your practice, and I forgot to mention, but on the dashboard slide, you can actually star certain measures. So if there are measures you want to always see at the top of your portal, because those are the ones you're focusing on, you can do that so that you're not having to wade through everything. Sure.
I predominantly see hospital patients as a consultant. I'm having over 90%.
Yep.
How are we going to get hospital charts to report this kind of, give you access to that sort of stuff?
That is
Very obscure as far as I'm concerned. I don't understand anything about this and what those of us that see just hospital patients are supposed to do with all of this stuff.
Yeah, that is an excellent question that has come up this weekend, and I need to get clarification on that. So I've been in touch with our regulatory counsel to get some more information about that, because I'm not sure about that answer as well. But I will definitely be getting back to, and if you give me your card, I will definitely get back to you on that. I think even our regulatory counsel indicated we don't have great answers around that. It's very not clear in the proposed regulation.
Thank you.
Yeah. Yeah.
One thing, the one thing I do know is that hospital-based physicians or neurohospitalists, their under MIPS and all these things that I was talking about, that is going to be handled differently. I know that for a fact because remember I said in the beginning, a lot of this is predicated on office space. So I know for a fact that, because I'll be dealing with this in our hospital, and I know for a fact that the hospital will probably, I don't know if you're employed or not, but.
No, I'll bill myself.
Okay, well, I know what we're trying to do in the hospital is set up our own measures in the hospital for our physicians so that they'll meet the measures that are similar to the measures that the outpatient doctors are meeting. But I know for a fact it's going to be handled differently. Because I read this just the other day for full inpatient doctors. I can't, but again, it's a work in progress.
Yes, hard to find it.
No, I mean, I believe me, you're not alone.
Yeah.
You're not alone.
Thank you.
Yeah, it's been a common question. Thank you, Dr. Black. So let's talk a little bit about progress on the registry. So as I mentioned, we are currently in a pilot phase. We have had a ton of interest, a lot of interest in the registry. And so this pilot phase is actually bigger than we had originally anticipated, which is fantastic. And I actually pulled the numbers on Texas before I came down. So we currently have 7 practices in Texas that are in the pilot right now in Axon, which covers 87 providers in Texas. And we have 5 practices that are on the waiting list already. So this is great participation in Texas. So we have a diverse array of practices participating in the pilot, and I want to mention here, because I also recently chaired a task force appointed by the current president of the Academy, Terry Casino, about small and solo practice specifically, and 57% of our participants in the pilot are in small and solo practice, defined as a single specialty neurology group of 5 or fewer physicians. So we've got great representation there. Again, we had originally projected 2,000 participating neurologists by 2017. That was the original plan. The board is going to explore whether or not we are able to and want to open that up sooner, given what's going on here now. And we'll talk a little bit about how Axon will potentially help with the MIPS reporting requirements. We've got over 900,000 total visits and over 341,000 patients into the registry already. So it's growing very quickly. As far as what we'll be doing this summer, the plan is to, again, accelerate that evaluation and make sure that the registry is meeting its goals. How did the implementation go from the perspective of sites? They intend to conduct surveys of the pilot users and find out about their experience, how they're finding the data, is it meaningful to them, and are the measures being captured accurately out of their electronic health record. So, and again, the board will be talking about whether or not to accelerate that implementation and open this up more quickly next year. And they'll be talking about it this fall. We've started talking a little bit about monetizing the data on the back end, so it's still in a very infancy phase, but the AAN business development team has been looking into this and exploring and talking with industry about potential interest in the data on the back end. So again, they'll be bringing a proposal to the board in September, but this is still a little bit in an infancy stage. As a result of recognizing that there will likely be interest in this data, the Academy established a data use policy, and they've also established a data governance subcommittee that sits under the registry committee to vet requests, look at the data, and that means both internal and external requests. We've already had a lot of people within the Academy and even members who want to do projects and committees who want to do work and things like that. So I think they're going to be really weighing those internal and external requests and figuring out what we can do. And they're going to ensure that any data that they're seeing in the registry is being used when it's appropriate throughout the academy. So if there's some piece of information that might help inform a guideline or something like that, making sure that that communication is happening. Okay, so tying this back to MACRA. So Axon has been designated as a qualified clinical data registry, a QCDR is what they call them throughout the legislation. This is an annual designation, so we're pleased that it's already designated and we're good to go there. Dr. Black mentioned that there are the 4 components of MIPS. With most people being in MIPS, at least in 2017, there are those 4 components. 3 of the 4 components are going to require some sort of data submission or attestation to CMS. So what CMS has basically proposed in the proposed regulation is that a QCDR would be an entity that you could submit all 3 of those needed data submission points through that registry. So there's there's caveats here because there's not a lot of detail that's provided to the vendors on how do they make that happen on their end. They're gonna have to write programs, or I don't know, I'm not a tech person, but somehow make that happen. And they haven't really given a lot of guidance on the requirements for QCDRs themselves, but we're excited that this is a direction that it's going and that we potentially would be able to streamline all of this reporting, because then essentially if you're in Axon, you report everything through that, you would fulfill what you need for MIPS, and it wouldn't have to be, piecemeal. So we're excited about that, but we're gonna keep watching it and make sure that we are developing things in a way that will allow that to happen. So a couple of resources on the registry. We have some great videos. They're not cartoony. They have graphics and whatnot, so it's not just somebody talking at you. So I encourage you to watch a video about Axon. It will give you much more of a detailed overview. And then we have a website, and that is where you can go to sign up. So right now I mentioned it's a pilot phase. And what happens is you sign up if you're interested, and then it will be a first come, first served basis when we open that registry up. So you can definitely go put your name down if you're interested in joining Axon. So now I'll switch gears a little bit and talk about the alternative payment models that the Academy is working to develop. These are these physician-focused payment models that Dr. Black mentioned before. So besides knowing that the system is unsustainable and that payment reform is coming, as Dr. Black showed us at the beginning of his presentation, why should we do this? Why should the Academy be doing this? Why should physicians look to do this? It's really about allowing neurologists to take responsibility to make diagnosis and treatment decisions, determine the needed resources that you need to care for your patients. And then really it's about capitalizing on early involvement so that neurologists can be a part of the solution, and neurologists can be designing the payment models instead of having somebody design something for us and then having neurology have to deal with what they have developed. So we're really excited to have had a small group of people called the Payment Alternatives team form within the Academy. You're very lucky to have Dr. Black, who is on our Payment Alternatives team, sitting here. He's a great resource for you. We have a diversity of specialties represented, including general neurologists. We have people from across the country. And really, we have actually 2 in Texas as well, so Dr. Black and 1 other, so it's great. The Payment Alternatives team is really tasked with monitoring the landscape, identifying neurology innovators, bringing their stories to the forefront, sharing successes, and then developing APM concepts and encouraging their implementation, which we'll be working on. So this is a really basic sketch. There's a lot more detail involved in each one of these steps, but essentially the way that the Academy decided to approach this was to develop the team. The team decided to contract with a consultant, Harold Miller. He's worked a lot with the AMA to help with developing some payment models. And we worked to identify the disease areas of headache and epilepsy first. And a couple of the reasons that we chose headache and epilepsy were that the costs of care vary in these disease states. These diseases are mostly cared for by neurologists, and they would, as Dr. Black mentioned, you have to, when you get to the APM side, have a certain percent of your patients or percent of your income that are involved. And so it was thought to be a couple of areas where we could potentially get there for neurologists that would see a large number of patients in those areas. We drafted concepts, and we are right now in a stakeholder review and comment period on those concepts. And I use the word finalize here, but I don't think I would use it if I could go back and change it. But the idea is that these documents are living. This is an iterative process, and as we continue to get feedback, we will continue to change them because we want them to meet with what's going to be effective out in the environment, what people are going to accept. I also want to mention the stakeholder review and comments is really extensive. We've reached out to obviously our sections on headache and epilepsy, subspecialty groups. We've reached out to all of the committee members that are on committees in our health policy area of the academy. So we're really excited about getting a lot of input from people and a lot of feedback. So it's just showing you, we've had some articles in some of our publications about these payment models. So if you've seen anything like this in an AAN publication, this has been the work of that payment alternatives team. So this is a graphic showing what Dr. Black was talking about in terms of the idea of advanced APMs wasn't really included in the legislation. This is something that Medicare just kind of came out with in the proposed regulation. So it kind of, I think, caught people a little bit off guard. But so the idea is that these physician-focused payment models or APMs are still, we're trying to figure out where exactly they're going to end up fitting in. Are they going to fit in as advanced APMs, or is it ever going to be feasible that one of these would qualify as an advanced APM, or are they going to sit more in the MIPS side? So just showing kind of they're out there, but we're not exactly sure where they're going to be yet. And just to note as well, the proposed regulations for advanced APMs, again, as Dr. Black mentioned, were very stringent and limiting, but the AAN and lots of other medical societies are definitely pushing for broader, more inclusive regulations. We need more people to be able to get there, so. So as far as physician-focused payment models go, I just included here some of the criteria that they had mentioned in the proposed rule, but payment incentives for high-value care, care delivery improvements, information ability, and enhancements. So still just trying to figure out what exactly this means. I mean, you read this and it's kind of, well, where do we go? So we're trying to figure it out. We're trying to be proactive and just put things out there and have people tell us no, right? So again, MACRA intended to encourage broad APM participation, but it also did acknowledge that there was a lack of primary care models available. So that's why they created this Physician-Focused Technical Advisory Committee, or PTAC. So the goal with our AAN models on epilepsy and headache is to eventually submit those models to this PTAC, who will review and make recommendations on APM proposals that are submitted by entities like specialty societies or the academy, and then send those recommendations to the Department of Health and Human Services, or HHS, who would then consider them for testing and eventually, if they're accepted, in theory, be approved as an eligible advanced alternative payment model. So as you can imagine, each one of those steps could take a really long time, so we'll talk a little bit later about how that's one of our main concerns with these, is that the timeline from the implementation could be so long. And as Dr. Black showed, there's that 5% bonus from 2019 to 2024, but those payments could run out very quickly if you've got processes that are going to take several years to be able to get things in place. So if this doesn't eventually turn out to be an advanced alternative payment model, perhaps it could turn out to be a MIPS APM, as Dr. Black talked about those a little bit, and this just goes through the criteria. Dr. Black mentioned that you'd be able to, that it would be partial credit for your CPIA, but I just wanted to mention CPIA would be a total of 60 points is considered 100%. So this would account for half, or 30 points of your CPIA. So if you're in MIPS and you're in a MIPS APM, you'd get credit for half of your CPIA score. So we have, again, the website is a great resource because it's always kept up to date with the latest information. So we have a whole web page dedicated to alternative payment models. And you can see actually the first item on the web page right now is still the commenting period. So if anyone wanted to go out and take a look at those, and you could send comments. I'm not sure if you can still submit comments through the web, but you can certainly send them to me or to Dr. Black or Kai, or anybody can get them to us. And we're definitely still interested in taking those comments if anybody would like to go out and do that. But I really encourage you to keep up on the AAN website. Okay, this slide is really deceiving, I realized after I made this, because Issues to address. There are lots of issues to address. There's only 4 bullets on this slide, but there are a lot of issues to address. These are really biggies. So really just the fact that there will be too few qualified advanced APMs, and Dr. Black showed the great statistics on the number of physicians that might actually be able to qualify under those. And then as I mentioned before, the timeline for developing the new models is very long, and we need to make sure that people are able to capitalize on, the 5% bonus, I think, is really meant to cover some of those infrastructure costs of implementing these things. So we need to make sure that people are able to access those dollars. And then of course the risk requirements are unrealistic and very, very complicated. So just to talk about the AAN's overall approach to MACRA and how we're advocating on the regulatory side now that this has gone into rulemaking, we want to emphasize choice, flexibility, simplicity, feasibility, clinical relevance, and minimizing administrative burden for physicians. These are kind of our gold standards as we're writing comments on these regulations. We definitely have been emphasizing the implementation timeline needs to be adjusted, not just for the APMs, but just in general for the program. The fact that everything is based on 2 years prior is a problem, because potentially then by the time somebody might be noticing something, you're already 2 years further down the road and not able to correct that. So, the legislation calls for CMS to try to narrow those windows, but we'd like to see that happen sooner rather than later.
People might be surprised.
Yeah, just a couple. We're working really hard. Like I said, we are here with you. I absolutely love coming to a conference like this and just hearing what are people talking about, what would you like your academy to do. Please, please, please reach out to us. We need to hear from you and know what it is you would want from us. What are you looking for? What would you expect your academy to have for you to help with this? We would love to provide it for you. So please, please let us know, or let your leaders know within your organization. But we are really working hard to try as best we can to develop practical resources, knowing that this is a moving target and knowing that we don't still have final regulations. But I mean, this is something that we are all hands on deck at the Academy. And of course, doing extensive member education and outreach. And we are really using every single AAN channel that we have. So just to show, we've got articles in AAN News, Neurology Today, both of the journals. Neurology, I think, is going to be coming out with an article, and NCP has had an article already. We have got practice management webinars, and we focus on MACRA in a couple of those this year, and I'm sure that will be a focus next year. We have in-person courses. We also, I skipped the Speakers Bureau. That's one of the most important ones. We have a network of neurologists across the country that have agreed to be a part of a Speakers Bureau and give more local talks, maybe at a state society meeting like this, maybe at Grand Rounds, or maybe even at an individual practice. So that's been working out well for us. We also created an animated video series about MACRA. It's very well narrated, so I encourage you to go out and watch that on our webpage. We also have an email address, macra@aan.com. So if you ever have a question, just submit it. We will try to get back to you as quickly as we can. And of course, as we talked about earlier, the Axon Registry, we really hope that this is going to be part of the solution for people, and this is going to be helpful. Also, I don't know why that red circle is there, I apologize for that, but wanted to show you the webpage itself too on MACRA. And again, this is kept up to date with all the most relevant and recent information, so encourage you to check back often to that. And I will leave you with just a few ideas and suggestions on preparing for success that are really high level and kind of basic as for what we know right now. But first and foremost, participate in PQRS. That's kind of the baseline for everything. I guess I should say EHR. Make sure you're on an electronic health record if you're going to choose to participate in this. Making sure that your EHR is certified, and also just being in communication with your EHR vendor to ensure how the transition will work. So if you're already using your vendor to report PQRS and meaningful use, ensuring how that process is going to work now under the new MIPS program. Consider participating in the Axon Registry, and as I mentioned, if you're interested at all, go get on that waiting list on our webpage, and investigate alternative payment model options in your area. Also, another thing is ensuring, this has to do with the resource use portion of MIPS, but ensuring that your patients are seeing a primary care physician annually. It has to do with how patients are going to be attributed out to people, but if there's any way to do that, I would encourage, we're trying to figure out some tools to help. That's something we're talking about on our medical economics committee right now. but encouraging that would be helpful. And then obviously checking back often for more resources as things are developing that the Academy will provide, and probably the website is the best place for that. That's all I've got.
To answer questions, and are there any questions? Yes, sir. Oh, we got and Pat, she's going to collect them as well. I'm sorry, but you also have microphones if you want to use those.
Question, Stu, who actually wrote the MACRA, or, the next question is, how are they accountable? Are they political or not?
I have no idea.
Legislative staff.
When finally the Gruber hit the television, the ACA, we let one person and a few people make this decision in a democratic society.
I don't know who wrote MACRA. I don't know. And, remember I showed you a slide and I said that our budget was $3.4 trillion, and clinical care only accounted for $2 trillion, and $1 trillion was other stuff. Maybe this is part of the other stuff. I mean, I don't know who wrote it, but I can tell you this: it came out of CMS, and it had a lot. And I know the politicians were not involved because, as I mentioned earlier, just talking to our congressman in Dallas, they were they couldn't believe all this stuff, and so. I just don't know who wrote it, but I can tell you whoever wrote it, they probably weren't really clinical physicians because it's a very complex thing and it's very hard for anybody to understand. Eddie?
I need to say one part to that. When the original law was written, CMS wrote it. CMS has some legislative oversight. Every committee has legislative oversight, but even within like the original, there's a bunch of sections that say, well, the secretary.
Pull a chair.
All
Pull
that
the chair.
means is that we're
That for
writing,
you?
that's what the legislators got, they voted on, but that the rules will
Oh,
be established
yeah.
later, and that's
I'll
all
take that.
established by CMS. So that's why this is an evolving thing, and there are opportunities that, we still have to sort of put our stake in the fire through advocacy efforts and so forth. Because they kind of wrote it to get it out to kill SGR and kind of figure, well, we'll fix it up later. But I don't think
Is
that.
that a little bit like we gotta pass it and then we'll find out what's in it, sort of? But, this is a crucial thing because we always kind of keep coming back to fixing it. We're as physicians, we are crisis management. We put out fires. But it seems like on this side of national policies and all that, to have such egg on the face all the time, and somebody writes some kind of thing like this in a hurry to, do something, and here all the politicians, everybody says, we have no ideas. And
Well, who wrote the Affordable Care Act? I can tell you how the Affordable Care Act came about. I know who the consultants were for that. The Affordable Care Act was basically a product of United Healthcare. And United Healthcare were the consultants for Obama. And United is bigger than Aetna, Blue Cross Blue Shield, and some of the others put together. So when I said earlier that it's an advantage for the insurance industry to put the risk elsewhere, believe me, that started with the beginning of the Affordable Care Act. The United were the major consultants, but I have no idea who the consultants were. We have a question: what is the cost what is the cost of the penalty annually? Well, I don't know that, and of course the cost is also going to be a reflection on your income. So it's a percentage of your income. So it depends on your productivity. So if you make, say you put on $500,000, it's going to be okay. So one of the things I do know, and correct me, Katie, if I'm wrong, I think about the average and maybe Eddie, was it the average physician in America? What is it, $80,000 a year for Medicare, or something like that?
87.
87. Okay, that's neurology. Okay, so the average neurologist collects 2014, $87,000 a year. So that would be 4%, starting 2019 of a hit. It'd be 4% of 80. That's why I say you got to do the math of 87. If you're that number, so I don't know. I mean, so it depends on your income. Are there some other questions that came through here? There's a hand up there. Why don't you? Is the microphone working? Because I don't hear very well. Well, just speak up loudly because I don't hear very well.
Seems to me with the way a neurologist, at least 40 to 60% will be earning a whole lot less than the rest of them. It seems to me that a nurse practitioner in private practice is going to be earning more without having gone to medical school very soon.
Well, I wouldn't.
They earn 95% of what we bill.
Yeah. Well, all I can tell you, I'm going to be politically correct here, but this is not my nature. But all I will say is that this started with the Affordable Care Act, where accountable care organizations were sanctioned by Obamacare. And as you know, in America, quite frankly, we are different. We are different than most large countries that have very large healthcare systems, from France to England, Germany, where primary care is really a very important component. But a lot of them have a different system. Some are, in fact, if you remember the British system, which was totally socialized, it's underwent a metamorphosis a few years ago. So we have always been different in the sense that primary care has not been the primary focus where it is in many other well-developed healthcare systems in other countries. Does that mean then that we needed to switch? Well, when you look at the gross, the percentage of gross national gross product that we're GDP that we're spending for healthcare, people have made a conclusion. Well, maybe if we go through the primary care model, it will be less expensive because specialists do charge more money in most of the things they do. Well, ACOs were developed, and I tell you, I know a little bit about ACOs. They are primary care-driven models. They were driven for primary care. When you look at shared savings, almost all the shared savings are going to primary care, and very little, if any, are going to specialists. So in our ACO, we have 2,700 members, 600 are primary care doctors. Well, this is an interesting thing. In the beginning, the ACO was, 4 years old, something like 4 years old, I think. Maybe 5 years old. So in the beginning, who gave a hoot? Because, nobody's income was affected by the ACO because it had to, get a patient base. Well, all of a sudden, people's incomes are starting to be affected by the ACO. And I go to these meetings every month, and sometimes more often, because I'm on these boards for the ACO. And there is constant turmoil and fight back by specialists who are now saying, what is going on here? Because all of a sudden their pocketbook's getting affected. So I will suggest to you that I don't think specialists are, of any kind, from our group to anybody else, are just going to be as passive about some of the changes in distribution of income that you're talking about, with primary care reaping most of the benefits. I'm going to predict that with time, the voices of a lot of very powerful specialty societies and specialists will be heard, and there may be some adjustments in that because we are a society with more specialists in primary care. So what do you think, Eddie? Do you agree with that?
Yeah, absolutely. And we fought hard to be included in that primary initiative for years, and finally it just went away. But that may come back in some form or fashion later on.
Yeah.
Trying to get included in that. But I agree.
Yeah. Bill, you usually have some comments.
I'm speechless for once.
That's the first time in all the years I've known you, you have ever been speechless.
We all thought, if you ask any one of my MS patients, who is your primary care physician? Guess who's right today?
Katie can speak to that because Katie's involved in that, you bet. Yeah. Susan?
Are there current statistics that show that specialty care is that much more expensive? Because the copays to see us now in many cases are $60. Patients get MRIs before they get referred to the neurologist.
Yeah.
And the
Well, in addition to that, you know, how many of you in this room know that there are neurosurgeons who, if you refer a patient with back pain to them, insist on an MRI before they see them? I mean, that goes on in our hospital all the time, and so you're treating the MRI, you're treating the patient, so that's not uncommon at all. Okay, yes?
It's kind of, you were showing in there that most of this, all this money's getting,
I can't hear you.
So one of the things that I've noticed is that there's all of this extra paperwork that's getting put out. Has anybody looked at what's happening is the insurance companies, the prescription companies, and everybody outsourcing these things to little subsidiaries that the CEOs and everybody's owning on the side, and then charging it back to the insurance company and costing the doctors immense amount of time and effort to answer all of these questions. In other words, all of these paperworks are not coming from the insurance companies, they're coming from outsourced companies that they own or their favorite congressman owns on the side.
Well, it's not just medicine. I mean, it's everything. I mean, if you're in the business community, which I'm fortunate enough to be in, just buying a piece of land is an absolute nightmare. So it's not, but you're right. I mean, our society's changed and the way we do business has changed and it's gotten a lot more complex.
That's what they're calculating as part of the cost.
Yeah.
It comes to that 5%
Well,
profit. It's a cost instead of a profit.
agreed. Any other questions? Yes, sir.
The elephant is medical legal liability and tort reform. You know, I mean, that hasn't come up. If you have the ACOs, which are capitated type things, this kind of stuff, over across the room with the knives and swords, the attorneys with adverse outcomes, and
Well, I'll tell you what.
countries where they have models that are like they don't have this degree of litigation.
Yeah, and I tell you, that's a good question. And Katie, you may want to mention something about this, and I'm going to just say one thing and bring it to you. First of all, in some of these alternative payment models, and I keep saying ACOs, you'll forgive me, but that's the only one I'm really familiar with of any degree of competence. Some of the liabilities are really going to decrease because we develop every single any successful ACO, even the big leagues like Partners and some of the others. Was the one in New Orleans I'm blocking? I can't remember. At any rate, they develop. You're developing practice guidelines and algorithms of care. I can't believe it. I mean, every meeting I go to, Best Care, for example, I'm a Best Care committee. The whole 3-hour meetings every month are developing from each section to develop algorithms of care that are to be used through the entire ACO for all specialties. Now, for example, in headache, I did have, and some of them are good. So in headache, we did a search on how much butabitol was being used. And I couldn't believe it. I mean, there was a ton of butabitol being used, mostly primary care physicians, of course. But I'm sorry to say some of our neurology colleagues were using a ton of it as well. So so I'm head of the neurology section. So what we did is we had our meeting, and I brought that up, and I wrote out the reasons why butabitol aren't to be used, and we actually got it off the formulary. So it's no longer on the Baylor Scott and White Quality Alliance formulary. So that's a good thing. I mean, so some good things can come out of that. Now, there are exceptions. When I say off the formula, I don't mean you can't write it. I mean that if you write it, you have to justify why you're writing it, because most people are just writing it because they're used to writing it, and they're writing, 60 butabitol a month. I mean, that's what you and I see I saw, but it's crazy. And that's got to stop, and it has stopped, and it's put an immediate end to that. So some good things, but the liability aspect of that from or ACOs, that actually is going to go, because everybody's been vetted. Everybody has vetted these practice guidelines, and they've been put forth by the specialty societies or committees, and that probably cuts down on liability because you have to follow those guidelines if you want to be a member of the ACO. Now, the question I have for Katie is, do you think, or how do you envision that same philosophy transferring into the PFPMs?
That's a really good question.
I mean, I never thought about that before.
Yeah, I haven't thought about that much either. I don't have much to add other than that's obviously something that I've heard several places, that this is a big piece that's missing here. I haven't thought about how that's a really good question. How that
Yeah,
would
I don't
translate.
know. It would seem to me that, so say, let's say, for example, let's just take headache or epilepsy, there's only two, or let's say we finally got it passed maybe 3 years from now, and that may be a realistic time frame. And let's say it's passed. Well, keep in mind, and when Katie was saying that the Academy, and I hope you can see from her discussion what an enormous, phenomenal job this Academy is doing, and she's leading it. I mean, and Eddie's involved in this as well with a lot of the stuff he's doing. I mean, our Academy is so far ahead of everybody else, it's unbelievable. But having said that, let's just say that, I don't know, the epilepsy or headache thing is passed. Well, let's say headache. All right, so now, people in this room are going to use, it's passed, we can use it as an APM, and it's probably going to be a MIPS APM, I presume. And so let's say that you're starting to use that. Now here's what we got in our comments, which is a very interesting thing, and I can see how that happened, because so many neurologists confused a PFPM with an algorithm or a practice guideline. And they wanted everything in, especially headache specialists, they wanted everything in there that was going to be the stuff that we do as headache specialists. I'm not anymore, I'm a has-been, but I mean things I used to do and what you do. Well, that's not what a PFPM is. In fact, it's got to be even more simple than it already is. You can't just have a payment for chronic daily headache, and that includes if they're going into an infusion center, if they're going into the hospital because they got comorbidities, and and how much time and effort. That is in the PFPM, but all the nuances are not, because that's not a practice guideline. We've got to get this across to our members that these PFPMs, whether it's neurology, cardiology, whatever it is, they're not practice guidelines, they're not algorithms for how to treat a patient and get paid. They are practice models so that we can get paid for all the things you do. Well, if we practice according to those, theoretically, everybody who sees a headache patient with certain conditions and they're eligible to be in this PFPM, they're going to have to do the same thing or they won't get paid. In other words, it's not an algorithm, it's not a practice guideline, but it's a recommendation for outcome, quality. The outcome has to come out to be the same no matter what course you take. Is that the way you understand it? And so theoretically, that might cut down on some of the legal liability. I don't know. I'm just throwing this out as a thought. Yeah, it's very, like I said, it's very confusing. It really is. Anybody else have any questions? Was this at all, I have a question, was this at all helpful in any way, shape, or form for anybody? Because we want to do this. We were talking, and Kai's not here, but of course, we want her to come down every year, but she can't, she probably won't. But somebody from the AAN probably would. But my point is, we would like to do this at every one of our meetings. And Eddie, I think you were taking a lead in that, and so is Bill. And have a part of every meeting, including our winter meetings, an update, if nothing else, on some of the stuff that deals with these changes. And again, remember what I said. You have to decide whether you want to be a part of it. But we want to be able to give you the knowledge to be able to make those intelligent decisions and the resources. So is this something that you guys would agree that this would be a reasonable thing to do at every one of our meetings, if not for an hour or two, as part of our programs? And alcohol, that's it. This is it. I want the alcohol, forget the Xanax. Thank you all, have a nice trip back. Thank you, Katie.
Thanks for having me.
Thank you so much, you were wonderful.
Oh, thank you.
Was I too pessimistic?
Mm-hmm.